Hello, my name is Dr. David Anick. I'm a psychiatrist with Partners Healthcare. Welcome to Part 2 of Management of ADD, ADHD in Primary Care for Adults. If you are not familiar with the presentation and diagnosis of adult ADD, ADHD, please watch Part 1. This video, intended for primary care physicians and nurse practitioners, will describe management of adult ADD, ADHD using stimulant medication once the diagnosis or likely diagnosis has been made. Stimulant medication is considered the first-line treatment for adult ADD or ADHD. Almost all of the prescriptions you write will be for Ritalin or methylphenidate or for Adderall, whose generic is called mixed amphetamine salts. A few patients report improved tolerability with the single stereoisomers, which are available as Focalin or Dexedrine. For patients who cannot take stimulants, there are second-line agents, of which Strattera or atomoxetine is the best known. This talk will focus solely on the prescribing of stimulants. Contraindications are relatively few. A past stroke or any serious cardiac disease, including valve disease, should give you pause. Angle closure glaucoma or any untreated glaucoma is an absolute contraindication, as is any monoamine oxidase inhibitor use in the prior 2 weeks. Stimulants can trigger a Raynaud's episode and can worsen a thought disorder or a manic or hypomanic episode, so stay away in those situations. Because stimulants are capable of being abused, be careful if there is an active substance use disorder. The trade-off is that a patient who is seriously in the contemplation phase or is struggling with sobriety may often do better if their ADD gets treated. Use your judgment and your knowledge of the individual. It's important to know the most common side effects of stimulant medication. Appetite suppression is common, and you can tell a patient that if it's lunchtime and they don't feel hungry, eat anyway. Some patients will report feeling revved up, agitation, or tremor. I try to back off on the dose when this happens. Sometimes a dosing schedule change or an agent change can help. I'll discuss switching agents later. Cardiovascular side effects are quite noteworthy. Please be sure to obtain baseline vital signs and watch for changes in blood pressure or occasional benign rhythm effects. Again, back off if these seem more than occasional or less than benign. Side effects like headache or sweating, these are trade-offs of severity versus benefit like you will have with many other drugs. Insomnia or sleep disturbance is a common adverse effect and can often be avoided if the last pill of the day is taken not too late, and caffeine is likewise limited. As with other Schedule II drugs, diversion risk is a concern with stimulants. A research study of young adults found that a yes answer to a single question could predict diversion with high probability. Namely, have you ever given away or sold your ADD medication? You can decline to treat someone whose attitude or intention does not seem mature enough. For new prescriptions, do check that they are not double dipping via the Massachusetts Prescription Monitoring Program. A common diversion issue is not patients' trustworthiness, but other people's temptation. I advise patients to bring only that day's pills with them to work or school, lest the whole bottle be lost or stolen. Don't make idle conversation about taking ADD medication, I tell them, since the wrong people might overhear you. Tell only trusted friends and family. And lastly, I tell patients that if they do lose their pills, I will not do a clinical override to get an early refill, and they are out of luck until the next refill would be due at the end of the 30 days. The process of treatment initiation is the same for Ritalin or Adderall. I give patients 60 tablets of 10 milligrams, and I tell them that they are going to be like a scientist and determine the optimal amount and timing for their medication. I tell them the unit we work with is a half tablet or 5 milligrams. The patient's job is to keep a log for the next 30 days. They can do it on paper or on their phone or an Excel spreadsheet if that's their style. I say record whatever you take, whenever you take a dose and how much. Also, every day make a note of how you slept, how your appetite and mood were, and any improvements along with any side effects. I tell them we are going to look over and discuss the log together at a follow-up in 30 days, so it's important that they actually do it. I tell the patient for the first few days, just take 5 milligrams every morning. Even if nothing happens, do that for a few days. If you feel no change, start taking 10 milligrams in the morning for the next 3 or 4 days. Maybe you notice something, but it wears off. Increase to 15 milligrams, but you can do it either as 15 all together in the morning, or you can space it out as 10 milligrams in the morning and 5 milligrams around noon. I tell the patient they are free to experiment with various combinations, timings, and spacings until it feels good and useful. I will say, even if you get something you like, try a few variations just to make sure you have found the absolute best schedule. Like you might end up liking 10 and 5, or 5-5-5, or 10-5-5, or maybe you will need 20 milligrams first thing in order to notice any change. Whatever you find, write it all down. But do this for just these 30 days and don't go over the 20 milligram total in any 24-hour period. So you make a follow-up appointment for 30 days later, and then you walk through the log with them. Nearly always, the patient has figured out a regimen that works for them. Sometimes they see some benefit at 20 milligrams, but it wears off. Those patients are the faster metabolizers who will need a higher dose. You can do another 30 days to explore doses and regimens between 25 and 40 milligrams per day. I suggest keeping to the recommended maximum of 60 milligrams per day. I have occasionally seen people who legitimately need more than that, but it's okay to refer these exceptions to psychiatry for monitoring. Also, emphasize that the purpose of this medication is for their ADD symptoms only. Do not let the patient take more for improvement of mood or energy. Do not have the patient treat Ritalin like it's a super espresso. If the patient has mood symptoms after the ADD is corrected, consider a comorbid diagnosis. Should you start with Adderall or Ritalin? It's a perennial question. Here you see the results of one large study. Response overall to Adderall may be a little better. Sometimes the patient has had a prior trial that worked. It's fine to resume what worked in the past. Or if they had a trial they didn't like, do the opposite. Side effects and patient preference will be your most common driver of the decision. Adderall may have a slightly higher association with psychosis due to greater dopamine release. So go for Ritalin first if there is a family history of bipolar or of any psychotic disorder. Both medicines come as either short-acting, also called regular or immediate release, or long-acting, variously called long-acting, extended release, or sustained release. The regular formulation gives the patient maximum control and flexibility, since they can add more to adapt to the need during each interval of the day. A typical case might be someone with a work schedule that is different on different days of the week as to when the departmental meetings occur or reports are due. The downside is the extra attention needed for monitoring and the risk of forgetting. And then suddenly discovering they're not getting anything done and, oh, I forgot to take my medication. Long-acting formulations offer convenience but lock the patient into a single dose and strength that is the same day to day. If a patient wants to use a long-acting form, first determine the optimal daily dose using the log method I described and get that working smoothly. Use the same total milligram per 24 hours for the long-acting. Slower release does not slow down how soon the medication will be felt by the patient because the long-acting typically have some immediate release in them. As patients become familiar with the two forms, some will realize that they have different needs on different days, so a mixed strategy may be appropriate. You can combine two prescriptions for a best of both worlds approach. Here you see a typical example where a patient has two prescriptions, 20 milligrams of XR every morning, but supplemented by either 5 or 10 milligrams later in the day, depending on what is happening at the job on that day, like an extra reading load or an evening meeting. I have listed on the slide here the most common long-acting formulations that you will come across. Anecdotally, I believe Vyvanse is the best tolerated of all the stimulant formulations. If you are having trouble finding something that sits well with your patient, don't give up without at least giving Vyvanse a try. Once you have a stable regimen, you can renew scripts between live office visits without seeing the patient. Traditionally, stimulant prescriptions required live signatures, and the maximum that could be dispensed was 30 days with no refill. But some insurance companies are allowing more if 4-ADD is written on the prescription. You can ask each patient to find out their policy, but the 30 days with no refill is still the standard, and you won't go wrong sticking with that. I'd still see the patient every 3 to 6 months. At these visits, ask how they are using their meds. For example, if it is a combined regimen, find out how much of the short-acting do they actually use. Ask about their target symptoms each time. That would be the items highlighted in their Part B of the ASRS, if you use that method for diagnosis. This was in my Part 1 video if you have jumped right into Part 2. This is also where you can best catch diversion or misuse. Watch for any evasiveness or odd answers when you're just having a conversation with your patient. Most patients will be delighted to tell you about how well your medicine is helping them. After several years of having this same conversation every 3 to 6 months, it can seem redundant, but I think it's good to monitor for slight changes and not let possible problems or mismatches build up. It keeps the patient cognizant that this is a medicine prescribed by a doctor for a medical condition. Also gives the patient a chance to express any other mental health needs. Be prepared to screen with the PHQ-9 for depression or the GAD-7 for anxiety, as appropriate. Tolerance is the exception, but it does occur. A patient may report need for dose escalation over the course of months or years. One estimate is about 20% of ADD patients experience tolerance. My strategy to prevent or minimize tolerance is periodic reductions or drug holidays. Most patients have days of the week when their full concentration level is not required, typically on a weekend. Sometimes patients say their Saturday chores require just as much medicine or they can't get started on them. So let the patient decide what their optimal day for reduction would be. My practice is to advise all patients to build this in. For one reluctant patient whose dose had gone from 20 to 30 to 40 milligrams, I enforced this by giving him 55 pills rather than the expected 60 for 30 days. I told this patient he had to decide which 5 days were his lowest priority and go half strength on those days. He hated it, but he did prevent further tolerance development. That individual was in recovery from opiate abuse, and anecdotally I believe tolerance is more of a risk in those with a history of substance use disorder. Lastly, let me say a little about switching stimulant medications. This may be necessary if your initial selection works for target symptoms, but there are side effects. I've already mentioned some approaches to sleep disturbances, including earlier timing of the last dose of the day. Switching is mathematically straightforward since all the stimulants are about the same milligram for milligram. If the patient is basically doing okay, I often give a partial switch the first month so that if the new one is worse, the month is not a total loss. Stimulants do not work for everyone. Some ADD patients will need second-line agents, which are listed here. These don't work like the stimulants, and they do need to build up in the system over several weeks. These will be a minority of your adult ADD patients, and I am not covering the second-line agents in this video. You are well justified in referring these individuals to be followed in outpatient psychiatry. That concludes Part 2. Adult ADD patients are often highly appreciative, and you can see the difference you make in their lives. Thank you for your attention and best wishes as you manage your adult ADD or ADHD patients.